Welcome everyone to today's webinar, How a Hospital System and Behavioral Health Provider are Improving Medication Access and Adherence. I'm Mackenzie Bean with Becker's Hospital Review. We'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We're looking forward to hearing your questions. Today's session is also being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. At this time, it is now my distinct pleasure to start today's webinar by introducing our presenters. Kelly Morrison is the Director of Remote and Retail Pharmacy Services for Cardinal Health, where she leads the nation's largest remote pharmacy services business, hospital outpatient pharmacy services, as well as central fill and community health center pharmacy businesses. Kelly's 24-year healthcare career includes co-developing the first national remote medication order processing service in 2003, in addition to the development of proprietary technology to enable the service that is now used by over 600 hospitals today. I'd also like to introduce Christy Barr. Christy is the Senior Vice President of National Pharmacy Operations at Genoa Healthcare. As a licensed pharmacist who joined Genoa Healthcare in 2006, Christy has held many different management roles at the organization, including Director of Operations, Regional Vice President of Operations, and her current role. And finally, I'd like to introduce Dr. David Silverman. Dr. Silverman is the Vice President of Pharmacy at Prime Healthcare, overseeing pharmacy, clinical, and operational services for 46 hospitals in 14 states. Over his 13-year career, Dr. Silverman has served in various hospital-level and corporate-level pharmacy roles, including pharmacy technician, staff pharmacist, critical care pharmacist, corporate clinical pharmacy director, and regional pharmacy director over 17 hospitals in California and Nevada. So at this time, I am pleased to turn the floor over to Kelly to begin the presentation.
Thank you, Mackenzie, and I'd like to thank everyone on the call today for joining our webinar. Doing more with less has been an expectation in healthcare for several years now, and unfortunately, this expectation remains the norm. And with complexities in navigating declining reimbursements amidst the need to expand clinical services, healthcare leaders throughout the continuum of care remain challenged to find a balance. As we look at new initiatives and approaches to expand clinical services, increased pharmacy involvement with direct patient care is critical across all care settings, whether it's clinically reviewing and fulfilling patient scripts, performing medication reconciliation and documented interventions, to providing patients education and improved medication access. Pharmacy is at the forefront of all of these initiatives and more, with a shared goal of ultimately improving patient adherence and outcomes. And while facilities have always had to think about contingencies in providing clinical services during natural disasters, often weather-related, this year has been especially challenging, with new challenges around the pandemic and even civil unrest. So as pharmacy leaders try to develop and evaluate approaches that enable them to expand clinical services while operating under financially constrained environments, they find themselves asking key questions around how they can maximize capacity while controlling costs. These involve identifying the types of services needed and evaluating how to align pharmacy labor to deliver. We are privileged today to have two pharmacy leaders share their strategy and approach to solving their specific challenges that enabled them to expand pharmacy services in a financially constrained environment. I'd now like to turn the presentation over to Christy to share Genoa Healthcare's approach. Thank you, Christy.
Thank you, Kelly. Thank you, everyone, for joining our call today. I'd like to talk a little bit about our outpatient behavioral health clinic. So Cardinal Healthcare has been around since 2000, and we have currently we have 548 pharmacies that are currently in 47 states, including plus Washington, D.C. So there has been a big spotlight over the last few years on mental illness in the United States, and luckily we've been working really hard, both with legislation federally and at the state levels, to reduce the stigma and encourage more people to get help with their mental illness. So 1 in 5 people in the United States live with a mental illness. 1 in 25 have a serious mental illness, and this is the box that Genoa tends to play in. There's so many medications and so much development going on out there. There's about 140 medications in development for mental illness right now. And there's constantly new therapies and treatments coming out every year. An average prescriptions used by a mental health patient is about 48 a year. That includes behavioral health medications and changes that come along with therapy to get someone stable. That also includes primary care medications where behavioral health has become so integrated with primary care, recognizing that the behavioral health patient really has a lot of comorbidities. So it's really trying to tackle the entire patient instead of just focusing on the mental illness. And Genoa co-locates pharmacies in community mental health centers and some FQHCs across the country. So how does our model work? So we really, again, work with those who have serious mental illness, and they suffer just really a particular burden. And our goal is really to improve their lives and outcomes. These people have complex and severe illnesses such as schizophrenia, schizoaffective disorder, and bipolar. They have trouble holding a job, finding a doctor that's willing to treat them, remembering to take their medications, or even being willing to take their medications. They really just have a hard time really keeping everything together, and it takes a treatment team, including pharmacy, to help them get there. They're invisible to most of society. If they're going to a retail location, generally it's not the people that the retail pharmacies wants to see in there. They're different. They may have tics, they may make noises, they may be unkempt, depending on where they are in their disease state, and we're just really not comfortable with that. So the whole mission of Genoa is to put these pharmacies in the home of the mental health patient so that they're being treated completely for through their medical providers and pharmacy all in one location, and Genoa is actually in their home. So as we hire pharmacists, it's really important for us to hire people who are compassionate and have empathy and are willing to do the best of both worlds in pharmacy, work as a clinical pharmacist with the doctors and nurses at the clinic, but also have the retail aspect where you're being able to deal directly with the medication, with the consumers. We had an independent study done in 2016 in Michigan to hopefully prove that our model works, and it did turn out well for us. So they took 5 of our pharmacies in Michigan that are co-located in community mental health centers and did a study looking at patients who go to the community mental health center and use Genoa pharmacy versus those who go to the community mental health center and do not use Genoa. So Genoa showed a 90% adherence rate. We had 18% fewer ER visits and 40% fewer hospitalization, and that's really because we focus on removing the barriers to adherence. So Genoa by the numbers, we have 3,700 employees. Again, we have 548 pharmacies in 47 states plus DC. We actually at Genoa consider ourselves having 2 sets of customers, both our clinic partners that we're co-located at, so the case managers, the nurses, the doctors, the clinical therapy staff, and then we also have what we call our consumers or our patients. So we just actually finished doing our NPS, annual NPS for our clinic partners at the end of Q3. And it was really interesting to see through the pandemic how everything worked out. We send out our survey to our clinic partners everywhere from the nurses, the case managers into the C-level. We also send the NPS service out to those inpatient facilities that a community mental health center may be running that we service, and also to residential homes that we service. So overall, our clinic partner NPS came back at 71%, which during the pandemic was better than we actually expected because there's just been so much chaos at the community mental health center level. And I'm proud to say that we have kept all of our pharmacies open about 98% of the time. So we have a great protocol for handling the pandemic. And even though our community mental health centers were closed for a period of time in some states, our pharmacies were able to continue working in the building and went above and beyond what we needed to do with the help of Cardinal clinical services to be able to make sure that we were still providing the service that our mental health patients needed. And I think that really translated into our consumer NPS score that came back in Q3 as 94%. So what's the role of our pharmacy? So we know that 50% of the prescriptions for behavioral health medication are never filled. If they have to take a prescription and leave the doctor's office without the actual medication in hand, 50% of the time a behavioral health patient is not going to go get that medication filled for a variety of reasons. And the role of our pharmacy, Genoa, is really to meet two of our company's mission's goals: increase medication adherence and remove barriers for patients to access care and medication. We want them to be able to have that access 24/7, and we're able to do that because we partner with Cardinal Clinical Services. We started that partnership about 2 years ago, and it's really been invaluable to us. Our clinics are open generally Monday through Friday, 8 to 5, some hours, a little longer, but generally those are the hours. And because most of the community mental health centers that we're co-located in are in areas that require high security, we may not have access to the pharmacy on the weekends or late after hours if the entire clinic is closed. So we really rely on Cardinal Clinical Services, their remote teams, to provide our clinical support and to help with transitions of care. So the behavioral health patients are not generally reliable to be taking their medications with them to doctor's appointments or a list of their medication, carrying a list of their medications with them when they are admitted into inpatient or even picked up through a jail system. So it's important that the caregivers at the hospitals or residential homes, any other physicians, and the jails are able to access pharmacy information 24/7. With that, we're able to do it with the remote support of Cardinal Health. The type of services that Cardinal Health provides for us are some clinical outreach. So any of our nurses, home caregivers can call and get prescription information. They can also ask medical questions, clinical pharmacy questions that they talk directly to a pharmacist to get the answer. And also our patients are able to call 24/7 and ask questions and get the information that they need on their prescriptions. We also have new prescription transfers. Genoa does a lot of proactive work to be able to ensure that we're getting refills and prescriptions out the door and delivered to our patients in a timely manner so that they're not running out of medications. But occasionally a patient will get a new prescription that after the pharmacy has closed, or they may not have made it in if they come to pick up their prescriptions to pick them up on time. So it's invaluable for us that Cardinal Clinical Support is there to be able to transfer those medications to a pharmacy that's close to that patient or caregiver that they can go pick it up. They also provide new prescription transfers mainly for our crisis units. And it's really important as there's having admits for patients in crisis or with our substance use disorder inpatient units to be able to get those medications right away. And they're able to call Cardinal and get that information quickly. We do a lot of patient profile requests. Those are, again, coming from our inpatient unit, hospitals, and even the jail systems. You'll see on the thing, it talks about 24% of other. And I will say Cardinal is amazing with our consumers because they will call them all the time. And we may have repeat people calling if they're not doing well in their disease state, asking many questions. And they're so patient and really sympathetic and empathetic for our consumers and really handle everything in a professional manner. So just in August, they completed about 1,300 patient support interactions for us and the profile and history for 260 inpatient admissions, which is key to providing that transitions of care. So how does it work? For our model, the prescription will be called in or e-scribed to our Genoa pharmacy location. If it's e-scribed to our Genoa pharmacy location, the technicians and pharmacists have access to our pharmacy system through a secure HIPAA compliant encryption. The clinical communication and documentation is all done. They will enter in the patient's order into our pharmacy system, and then they will make that transfer and do all of the clinical documentation and pharmacy documentation that needs to be done. And then transfer that medication order to a local pharmacy for either delivery to a patient or a residential home, or for a patient to go directly to pick up. The nice thing is that every morning when our pharmacists come in, they will have a report from Cardinal Clinical Services saying exactly what happened and what interactions that Cardinal had with our consumers or a residential facility overnight. And that they actually document everything, not just prescription transfers, but if a patient called to ask a question, if a nurse called to ask a question, or they were looking for a profile, so that our pharmacists can follow up with whoever that interaction was with, to make sure that they have everything that they needed and that the interaction is completely cleared out. So the benefits of off-site pharmacy support. It's definitely expand our pharmacy service from the on-site pharmacy team, counseling, patient consultations, especially again for our inpatient units. We service mostly 16-bed inpatient units, but we also have hundreds of residential facilities across the country also. And it's a great resource. The feedback that we got when we switched to Cardinal Clinical Services was amazing, because our partners were very excited that they had someone where when they called, they didn't get an answering machine where they had to wait, 2 to 4 hours for someone to call them back. They immediately talk to someone. They will talk to a technician who will triage that, handle the situation if they can, and if not, they will triage that to the appropriate pharmacist to handle the situation and talk to them. And that was so much appreciated. Our prescriptions are delivered to the facility if necessary within a 4-hour window is what our contract says. Generally, those prescriptions are given to them within 2 hours. So it's been exceptional customer service that we've had from there, and it's really, that is a driver of increasing our NPS scores with our clinical staff at our locations. That is really what has driven that up over the last couple of years also. They also ensure that we have coverage despite of emergency situations, which again, I think 2020 has really just kind of outdone itself. It's tested us in, I think, every way possible. So they have actually provided excellent service for us at the drop of a hat when we've had civil unrest across the country, COVID closures, hurricanes. And in fact, as of today, I think they're covering 9 pharmacies for us that have been impacted by Hurricane Zeta that just run through. So it's just been great for us. I can't say enough about the timeliness of response and activating this emergency service at the drop of a hat for us. So it's really been amazing. So things to keep in mind if you're looking at doing this kind of services is really identify your needs and goals. So we used to have another provider that provided after-hours service. And so when we went looking for a new person, when we went looking for a new provider, it was important for us to come to them with the issues we had before and be very upfront. For Genoa, we are a nationwide company. We need to make sure that we had a partner who was legally compliant in every single state. And working with the team, with Mike, Francis, and Amy Fortune, it was a great discussion and planning session of how are we going to implement this service into our sites. Really make sure that you keep an open mind and seek the expertise. So again, we had some services before, so we had a policy and procedure in place with our old provider. I provided that to Cardinal Health and asked them to take a look at it and then, come up with a plan or policy and procedure that would work for their end of the process, and ours, and something that will work for us to make sure that we were working together. They came back and added details that were great and provided much better customer service, and it was a much easier workflow for not only our pharmacy staff, but for our partners also. And then don't underestimate the needs. You need to make sure that you ensure that your implementation of new delivery systems goes really smoothly. Ask whoever you're going to work with, like Cardinal Clinical Services, to provide a proactive plan. So we actually took about 3 months to really plan out, because we were converting about 375 pharmacies over from one provider to another, and we had about 30 days to make that change. So this was really big and key for us, because we had so many people relying on these after-hour services. We could not really afford for us not to hit the mark. So we worked on an implementation plan, and I have to say it really went off flawlessly. We had maybe a couple of little glitches. Those were worked out immediately, and immediately we started seeing the customer service and the information I was getting back, the feedback I was getting back from our pharmacists was that we really knocked it out of the park, and switching to Cardinal Clinical Health was really the best thing we could have done. So I just think I can't say enough about how good this was, how good this was for us. And you get ongoing support. So we still have meetings, we get reports from them, we share information back if we would have any medication errors. I honestly don't think we've had one in 2020. So it's, again, a really great process. And coming up with the training for our team and for their team on our pharmacy system was just really made easy by the team effort that they put into making this implementation a success. So with that, I'm going to turn it over to David Silverman with Prime Healthcare.
Thank you very much, Christy, and to everybody in the call, good morning and good afternoon, depending on where you're listening from. For this portion of the presentation, I'm going to be highlighting the operational and financial considerations for 3 different models of remote order entry services, and also really focusing on how remote order entry fits into disaster preparedness for hospitals and health systems. So just a little bit about Prime Healthcare and how our own remote order entry strategy has evolved over time. We currently do have 46 hospitals across 14 states from coast to coast, New Jersey, California, Florida, Texas, really a lot of different places across the country. And one thing to really highlight with Prime is that these hospitals really do vary significantly with regards to size, their patient volumes, the clinical service lines they provide, the acuity, the hours of operation for their pharmacies, their EMR systems, their OmniSeller Pyxis, ADC infrastructure, and also a lot of other operational areas have a lot of variance in them. When we look at our distribution of those 46 hospitals, we have some states like California, they have 16 hospitals, some are close together, some are far apart. We have some states like New Jersey, Pennsylvania, and Michigan where we have a group of hospitals, 2 or 3 that are close together with similar service lines and usually similar EMR systems also. But then we also have these hospitals that are much smaller, more community-based, and they're one-off. So one hospital in Florida, one in Alabama, and one in Indiana. So really, how do you take that sort of footprint, these different infrastructure issues, and how do you put together a cohesive program that prioritizes patient care while at the same time keeps down costs? And that's really what I hope to highlight for you all today. There's obviously a lot of impact from 2020 that's been discussed already, but one important disclaimer that I want to highlight is that there's been previously a lot of red tape. States like Florida, for example, if you're going to do remote order entry for that state, you need to have someone licensed in Florida, for example. We'll get more into some of those considerations for choosing a partner, but with COVID-19, there's been a lot of waivers issued. It varies by state, but if you're looking to implement a remote order entry service and you have hospitals across multiple states, whether you're in-housing it, which we'll discuss, or outsourcing it, to a vendor, you know, state licensure requirements and waivers are something that have to be considered at all times. So in general, there's 4 different remote pharmacy service models. They're listed for you on the slide. The first is a shared hospital or sister hospital model. This is usually where you have like 2 or 3 hospitals working together. The second one is sort of like a hub and spoke or a centralized hub where you have essentially a dedicated team coming in at night, or if you have expanded hours, and they're taking care of a large number of your hospitals. So the first scenario, you're leveraging staff from one hospital who's already there, and they're taking on additional workload to cover a smaller hospital nearby. In the second scenario, you're essentially running a program similar to what Cardinal or other vendors offer and taking care of, you have dedicated staff whose only job is remote order entry services. So that's sort of the in-house model. The third model is when you contract with a vendor like Cardinal or partner with them. And those are really the 3 remote order entry service models we'll be talking about. But the fourth piece, which is very relevant and important to today's presentation, is also how does remote order entry services fit into a disaster preparedness model? So within Prime, we've used all 4 of these models for our national pharmacy operations. And of the 46 hospitals in Prime, only 18 of them actually have physical pharmacy staff on site 24/7, and the others use some form or variation of remote order entry services. In California, we did have this centralized hub model that we converted over to the vendor model with Cardinal. So that's 11 hospitals that we switched over to the vendor model. And then in other states like New Jersey and Missouri, Kansas, we have the sister hospital model. And we'll also talk about how we've implemented the disaster preparedness component of remote order entry nationally. So if anyone on the call is from a hospital or health system, I'm sure that you've all recently dealt with large and unpredictable fluctuations in hospital patient volumes. We all know that universally, hospitals have different codes. They have a universal code system to deal with disasters. So things like active shooter drills, code triage, bioterrorism, things of that nature. But in addition to these universally recognized or national emergencies, there's also regional variances that we see. So things like the natural disasters that were discussed earlier today, hurricane disaster plans, earthquakes, floods, and recently the social unrest with the riots and protests. So there's also regional variances to disaster response. 2020 has been unique because now we have a national pandemic, so there's also a national disaster preparedness model due to COVID-19. And there's also been a higher frequency of those natural disasters that are prevalent in 2020. So 2020 has humbled us, and it's really forced us to evaluate hospital operations and to come up with disaster plans that include various levels of downtime or service disruptions to account for up to, let's say, a 95% reduction in staff, or a potential patient surge of up to 200 or 300% normal capacity. So really, as it pertains to disaster preparedness, this is the key question and planning that you need to have in place proactively, and we'll talk about that more over the course of this presentation. So right now, our current footprint is that 11 of our hospitals have partnered with Cardinal Remote Order Entry Services for routine overnight coverage. So again, that's sort of the vendor model for routine coverage. But as a component of disaster preparedness, based on our system infrastructure, we also have Cardinal available 24/7 to provide emergency services to 19 of our hospitals. So if you're really trying to decide between doing an internal model, so a shared hospital model or a hub, versus partnering with a vendor like Cardinal, really the best thing to do to start that process is to start off with a business case. There's significant clinical, financial, and operational considerations that we'll be discussing momentarily, but overall, both models have pros and cons, which must be weighed as it pertains to your current infrastructure and needs. You also need to be very careful when looking at the true costs or hidden costs of not having a hospital pharmacy open 24/7. So there's certain things like on-call pay. How often are staff required to come into the hospital to mix strips? You might be spending more money on pre-mixed drugs or 503B vendors. Or if you have a high patient volume or acuity where a delay in having a pharmacist on site, let's say mixing TPA, Kcentra, things like that, if you're a trauma center, if there's a potential to have patient harm to occur. So really it's going to depend on we'll talk about this in more detail in a second, but really, is it a small hospital, low acuity, low ER volume, not a lot of ICU beds, or are we talking about a level 2 trauma center? I just want to make sure my message here is not that, you can outsource everything and there's no physical staff needed on site. It really has to be tailored to your patient's needs. So the 4 key considerations that we need to kind of look at are size, technology, standardization, and flexibility. A better word for size, or a word that should be combined with size, is probably complexity. So we need to look at for the first part, we need to look at the size of the hospital, the size of the health system, what's the distance between those facilities, what's your current system infrastructure, so are they on different EMR systems, different workflows, and you also need to look at typical patient volumes and acuity. So a good example of this might be if you have a large high acuity hospital that's close to a much smaller low acuity hospital. Depending on the infrastructure and specific hospital needs, this is typically a good arrangement for a sister hospital coverage model. The second important consideration is technology, so things like the hospital EMR or ADC systems. So using Prime as an example, and we also live in an era of healthcare acquisitions and mergers, you have a lot of infrastructure variances with the EMR or ADCs. So there's a lot of upfront challenges when implementing a shared service model. This means you have to train people more. There might be interface issues. So a lot more of the software backend training type of considerations that must be considered as it pertains to technology. Going back to that similar point of mergers, acquisitions, it takes time to change the culture of a company. It takes time to change the culture of a hospital, and standardization, depending on what we're talking about, could take years. So you might see nuances or variances in clinical service lines, nursing workflows, and pharmacy workflows, in addition to policies, procedures, order sets, and formularies. So if you're trying to cross-train your staff in a shared service model or a hub, that's a lot of training you need to do upfront to maintain that service line. And we go through some specific examples of the training and financial costs later on in the presentation. But really the key consideration here is, what are your upfront costs, what are your upfront challenges, and what are the ongoing maintenance challenges if you were to lose staff? And kind of as it pertains to the viability of a program, flexibility is probably the most important piece to this. Really, what is your capacity to flex the program up and down to meet your operational needs while also keeping down your costs? Most hospital systems today have seen a drastic reduction in both inpatient and outpatient volumes, and we're being squeezed to reduce staffing as much as possible. So if you have a centralized hub model, your costs are fixed. Just because you have a reduced patient volume, those are full-time employees. They're just doing less work, and there's nothing you can really do about it. And we're going to talk more about that momentarily. So those are really the high-level considerations from a routine service perspective, but I also want to highlight them from the context of disaster preparedness. So going back to those questions that I posed earlier, what would you do if you only had a few days to set up a program because you have a 95% reduction in your staff or a patient surge of 200 to 300%? Really, the key here is to have a plan, be proactive, and to practice it. In Prime, we have 3 hospitals in New Jersey. They're similar in size and complexity, same EMR systems. So for a disaster preparedness plan, it makes sense that they would cover for each other if one of the hospitals had a major issue. But if the challenge happens to be a natural disaster or a patient surge, then most likely the 3 hospitals would be impacted uniformly. So each hospital has a different level of downtime. Part of that plan is a shared service model, but then what happens after that? And that's when an emergency vendor partnership, such as with Cardinal, comes into play. So whether you're exploring the idea of expanding pharmacy services to 24 hours, making a shared service model, creating a hub, There's some additional considerations, including staff experience, the startup costs, and the maintenance costs, and especially employee turnover due to work satisfaction. So I want to be fully transparent with everybody on the call here. After I finished my residency, I actually started my career working the overnight shift in a large inner city level 2 trauma center. We provided a remote order entry service for a smaller sister hospital about 20 minutes away. I did promise my boss when he hired me. I mean, I had student loans. I was desperate for a job. He said, look, I'll give it to you, but you have to stay here for a year. And I promised him, and I thought I would. I only lasted 8 months. And that was after receiving about 2 to 3 months of extensive training across the various shifts and clinical service lines. So when you work the night shift in a busy hospital, you have to be cross-trained in everything. There's NICUs, there's trauma, there's a lot of different service lines, some chemo, unfortunately. So you have to be highly trained to be able to respond to any issues that could come up. But for me, the breaking point was when I fell asleep on my break while eating M&Ms at 3 o'clock in the morning. So it just really was not a good fit for me. And so if you think about it, your overnight pharmacist might be the highest cost, and that might be due to shift salary differentials. And also they're the hardest shifts to cover if they leave for PTO or if they leave for another job. You know, if there's a holiday and you only have a few of the pharmacists on staff, they might fight for holidays, for example. So as I just mentioned, they have a lot of cross-training. And again, it takes a long time if one of them leaves to get a new staff onboarded and trained. Even if they're an experienced hospital pharmacist, they have to be cross-trained across everything to cover the night shift. So you're looking at least 2 months to replace somebody in any sort of overnight position or program. From my own experience, I lasted 8 months, but what we saw in California was staff turnover by about 8 to 12 months also. A lot of people will work an overnight program to get their foot in the door for hospital pharmacy. And the second something opens up that's full-time on the day shift or evening shift, they'll typically leave for that position as soon as it becomes available. So generally the costs that need to be considered are your upfront IT and infrastructure costs. These are things like hardware and software. So if you're developing a hub, then that's something that might be more expensive. But if you're integrating it into a current workflow, then that might not be a big issue. Again, this varies significantly between hospitals and health systems, and it really depends on the scope and ambition of your program. You're going to need to plan for things like holidays, sick days, and staff turnover. Again, these are full-time employees that are working for you, and their costs are fixed. When we see COVID, we see 30 to 40% reductions in admissions, but the costs, so we have a drastic reduction in patient care, but our costs to take care of those patients are essentially the same. This is in contrast to a vendor model such as Cardinal, where you pay for exactly what you use. So if we look at the program we had developed in California as an example, we had a centralized hub of 11 hospitals with 4 different EMR systems. In order to accommodate a volume of about 30,000 lines per month, we needed a labor pool of 10 FTEs. We needed somebody to manage the program and also per diems for the call outs and flexing up and down if they had a capacity issue. An important consideration that you need to consider is how your hospital can measure and define line items versus vendor standard definitions of line items. So when I say that the order volume was about 30,000 lines, a line item could be a new order, discontinuation, or modification. Different EMRs have some reports built in, but you want to make sure that you're talking apples to apples when you're evaluating your own workload versus the potential financial impact of partnering with a vendor. So this final slide breaks down the labor costs and considerations for an internal program. And if we were to hire 10 FTEs with 4 weeks of training, this is very conservative. It could be 1 month to 3 months. Accounting for PTO, holidays, overtime, and benefits, we would expect an annual cost of the program of about $1.7 to about $2 million. And this is pretty conservative. This is not taking into account the upfront infrastructure costs, any issues with employee turnover, and a lot of the other challenges that may arise. And again, so going back to the value of a partner, such as a partner model such as with Cardinal, you don't have to worry about training your staff. You don't have to worry about the startup costs. You don't have to worry about, my volumes are down. You don't have to worry about most of those issues. You pay for what you need. And the value of having them as a backup for our disaster plans, it used to keep me up at night back in March. What's going to happen if something happens to all my New Jersey hospitals? Now I know, I have dedicated remote order staff that can help me take care of those patients and those employees in their time of need. So really having a proactive approach to disaster preparedness through a remote order entry service model has really helped us in the 2020 landscape. So I really want to thank all of you for the opportunity to present this information. And at this time, I'll transition it back over to Kelly, who's going to be going through some questions and discussion.
Thank you, David. At this point, I'm going to go ahead and turn it back over to Mackenzie with Beckers to facilitate a question and answer portion of the presentation today.
Great, thank you so much, Kelly. And thank you to Christy and David for sharing so much great information during this presentation. We'd love to give our audience members the opportunity to ask any questions they might have at this point. So if you do have a question for either Kelly, Christy, or David, please feel free to submit those by typing them into the Q&A box you see on your dashboard, and we'll try to get through as many questions as we have time for. Perfect. So it looks like this first question came in when you were speaking, Christy, about your experience at Genoa, and the audience member says, you have achieved a remarkable adherence rate in a challenging population. What strategies and tactics have you found most beneficial to achieving this commendable adherence rate?
So I would say the secret sauce for us, not so much of a secret, but is really we provide a high-touch model. So we reach out and call each of our consumers every month to check and see how they're doing on their prescriptions, if there are any issues, and we're able to talk to them and see if they need refills or be able to push them back. We also provide multi-dose compliance packaging for our patients, our consumers, and they can get those, either a week at a time, 2 weeks at a time, whatever, up to a month at a time, depending on where they're at in their disease state, and discussing with their physician what would work best for them. So I think those are two of the key. And then also we provide various delivery methods for patients if we have to have delivery to their home.
Okay, so it sounds like that high-touch model, multiple delivery options are really part of the key to that successful adherence rate. So thank you. And David, to your point, sometimes something relatively minor can impact staffing for a smaller hospital, say unplanned leave for 2 employees, for example. What are some other unexpected situations your pharmacies have experienced that have caused staffing levels not to be adequate?
Well, when you say like the staffing levels are not adequate, we always had a plan in place. That's the whole point of the disaster plan. We always had a plan in place to address staffing impact. But if the question is what are some other risks that could potentially cause a reduction in staff, I think COVID-19 is the perfect example. You have one person who tests positive in a department of maybe 10 people, and let's say that person worked 2 shifts with 8 different people. If you follow CDC guidelines, you just wiped out your whole department. So 2020 has been a huge challenge for us with this sort of issue, and we've implemented things like block scheduling to try to mitigate risks. And we do everything we can to try to protect our employees. So natural disasters and a lot of the other issues we discussed, I think all kind of are relevant discussions to this question.
Perfect. And it looks like we have another question here for Christy. This audience member is asking, knowing the demographics of your patient base, how has the patient population responded to your team providing them with 24-hour access to clinical medication resources? Have you seen an increase in patient loyalty?
Yes, absolutely, we have, especially since we made the switch because our other provider was not as reliable. So it made a big difference. It helped us also be able to not only with our outpatient patient population, but with our inpatient and residential home. There's a lot more stickiness there because they know that they have the clinical service provider who is very easy to get a hold of. And our consumers, we definitely have seen an increase in our penetration rate and retention.
Wonderful. Thank you for weighing in there, Christy. We have another question here from an audience member who's asking, you mentioned that on-site staff are able to expand services when supplemented by a remote pharmacy model. What are some types of examples of those services?
So is that a question for me? Just to clarify, sorry.
I believe either Chrissy, you want to take it, or David, you want to build off? Feel free to weigh in.
Sure. I mean, just quickly from the hospital perspective, most of the time, a lot of the time is spent for pharmacy doing order verification workflows, and that has been shown and proven to be safe and effective when done remotely. That's not something that you need to physically be required on site for, and that's not something that you really need a lot of high touch with the providers. If you have someone doing 95% of your orders and you have your staff doing targeted interventions and the remaining 5% that are high impact, that's really how I see this evolving over time.
Yeah, Christy, anything you want to add in there too? Just want to give you the opportunity to weigh in if you'd like.
Yeah, no, that's fine. I mean, for us, it's really after-hours services, so we're not really using our resources in a different way. We're just providing more service by having this clinical service available when the pharmacy is not open.
Wonderful. Well, you all have shared so many great thoughts today. I appreciate you giving some insights to these additional questions. Before we go ahead and end today's session, though, I just wanted to turn the floor back over to you both one last time. Are there any final thoughts you would like to share before we end?
Sure. I just want to again say thank you to everybody for taking the time to attend the presentation today, and happy to answer any specific questions or operational considerations when looking at these types of programs.
Yes, and I'd like to say thank you for everyone too. Lots of good questions, I think, today. And all I can say is doing these type of clinical services and having a partner like this is again, can be invaluable and really increase your customer satisfaction significantly, either in an outpatient or in an inpatient mother mesh. Cardinal Health does a great job with training, implementation, and any type of troubleshooting if there happens to be an issue. And in this constant changing world, I don't know how we would be able to handle with all of the things that 2020 has dished out all at one time. So I want to say thank you to them, and thank you for allowing me to present today.
Wonderful. Well, I would just like to say again, thank you to Christy, David, and Kelly for such a great presentation, and thank you to Cardinal Health for sponsoring today's webinar. I hope everyone enjoys the rest of your day, and we look forward to having you join us for future webinars.